I'm Dr. James Murphy of Breastfeeding Fixers, and this is an explanation of what we do for patients who arrive with an infant or a child uh, with a suspected tongue tie or upper lip tie. First, we have you fill in a 4-page medical birth history for the mom and baby. This tells us what the risk factors were for the delivery, what's been happening since the delivery to the current time, and how well the baby is doing, how well you're doing with milk production, any damage to the nipples, any pain on latch, and whether the latch is adequate or not, and how well the baby's doing with their pediatrician. They then, on arrival, get a weight to see where we are relative to birth weight. We examine the baby to make sure that we know exactly what we're dealing with anatomically, how thick a tongue tie might be, where it attaches to the tongue, and what is going to need to be done to release it. We also examine the upper lip to see how well it inverts. It covers the nostrils of the nose easily, whether it rises up as a thick triangular membrane between the lip and the gum, and any variation on that might be significant. I then sit down and advise you about what we found and go over what needs to be done to release that. The advice includes use of a cream, which is 2% lidocaine, 2% prilocaine, that we put both on the floor of the mouth and on the upper lip frenum to begin the numbing process. 5 minutes later, we can inject lidocaine, 2% lidocaine with epinephrine that will complete the numbing process and also constricts blood vessels to minimize any blood ooze after the surgical release. So there's no risk in either the application of the cream or injection of the liquid unless the infant has prior experience with either of these medications and could possibly be allergic to it. The risk of the procedure, of any surgical procedure, are bleeding, infection, and poor cosmetic results. We have found bleeding to be minimal to nothing in the mouth floor. There's a little bit of ooze that goes on for 5 minutes afterwards, but it's very minor. The upper lip has a much more rich blood supply and can ooze more. We will hold a dry gauze pad on that wound for up to a minute. If there's significant oozing after that time, then we use a gauze pad with Afrin nasal spray on it, which that constricts blood vessels further. And if it's still oozing after 3 minutes, then we apply a silver nitrate stick that cauterizes the wound and prevents any further bleeding. It also helps to improve the quality of the wound healing for the upper lip. Infection does not exist under 6 months of age, except in incredibly rare cases that are reported in the literature. But for all intents and purposes, no infection occurs in the mouth, the lip, until the baby is crawling and putting everything the baby finds on the floor into their mouth. The cosmetic result is the main concern here, is that when we release a tight tongue tie or upper lip tie, that we do need to do active wound care following the surgical release. For the upper lip, this involves doing nothing for the first 24 hours after the release, because during that period of time there is potentially excessive oozing and discomfort to the baby. And we lose nothing by waiting 24 hours before beginning our active wound care for the upper lip. After 24 hours, we stand at the head of the baby, pull the lip up all the way, place the thumb horizontally, crosswise, over the gum, press down on the wound, rotate the size of a dime 5 times, and this will release any attachment that has reoccurred between the lip and the gum. We do this 3 times a day, first thing in the morning, early afternoon, and then before bedtime. And we do this starting 24 hours after the release, and we do it for 20 days, which allows the wound to heal completely in about a week. And then wounds really pull tightly together and can rise up as a ridge in the center if we don't continue to do that wound care for additional 2 weeks after the wound has healed. So this results in 3 benefits. It releases the lip restriction and allows it to go flat onto the breast so that there's a good seal and almost no air swallowed while the baby is nursing because of that good seal. That's for breastfeeding. Later on, when the teeth erupt, if there were a frenulum or frenum up on the other lip, breast milk can be trapped on either side of that frenum and then come down as a thin film over the anterior surface of the teeth and cause anterior tooth decay. This has been well documented to occur only with breastfeeding and only with an upper lip tie. We completely eliminate this by releasing the upper lip tie. Also, by continuing on for a total of 14 days after the wound is healed, we prevent a ridge from arising up where the frenum was attached, and this prevents any problems with the baby experiencing pain when you're teaching the baby or the infant, now the older child, to brush his own teeth, his or her teeth. The toothbrush would hit that bump, the baby's complaint of pain, and resistant to cooperating with brushing the teeth. Once we keep that wound completely flat, we don't have any issue with that. The floor of the mouth is not forgiving. It has very little sensation and very little blood supply, so we don't have to deal with significant pain and bleeding. However, in the first 48 hours after the release, there is inflammation in the wound. So the inflammation builds for 12 hours, it levels off, and then it begins to go away. And all of our families have told us it's the first 24 hours that's really tough to get through because of the discomfort due to the inflammation. And after that, the second 24 hours, minimal discomfort, and after that, almost no discomfort. So we provide you with a topical anesthetic you can take home. This is oil of clove. It's a full strength solution we get from a specialty company. We dilute it to a 1% solution with coconut oil. This helps to numb up the wound before you do the wound care. And the coconut oil is anti-inflammatory, so it helps to calm that inflammation. So putting the oil of clove solution onto the wound, after we fed the baby, and the baby is really calm, we put the oil of clove on there for 15 seconds. We wait 5 minutes for it to actually have its effect, and then do the wound care. We will show you 2 different methods of wound care. One using a tongue depressor to open the wound, which has to be done 6 times a day until the wound completely heals. If it's done well, we've had the wound heal in 5 days, but our typical time is 7 to 11 days that you need to do the wound care 6 times a day in order to have the optimal results. You can get fairly good results without doing wound care in many infants, but when we're going through this procedure, we want to get optimal results. So we get the most extension of the mouth floor by doing active wound care. This is only done for that 7-11 days, and then that is a permanent improvement for the rest of the infant's life. So it's a short-term discomfort for long-term gain, and we feel it's well worth doing that. The tongue depressor is preferred by most of our patients to open the wound, but we can also use a Q-tip and show you how to put that into the wound, push down and open the wound that way too, if you feel the Q-tip is a better way of going at it. So we have you practice in the office doing the active wound care with the tongue depressor and the Q-tip, and let you decide which you want to use, and then give you a good supply of that to take home. This is we find that at least 50% of the families have an outstanding result when they come back 2 to 3 days later. If we see you on a Friday, we have you see you on a Monday, or if a Monday or Wednesday, we see you 2 days later. And we call that a potential course correction visit. That allows you to do the wound care for that period of time and then show us what you've been doing. We look at the wound to see if it's healing the way we want, and if it isn't, then we can ask permission for you to numb it up again, reopen it, any area that's closed down, and then start over from a fresh, fully open wound. And now you have that experience under your belt, and it seems like 99% of our families do extremely well after that. So half of our families will need that course correction visit, and we don't know who, so we have everybody come back so we can find out who's doing well who's not doing as well. And then we also have Leilani Wild, IBCLC, Lactation Consultant, in the office, who helps the babies to latch immediately after the release. And with each visit, we do, together, we do a feeding assessment of how feedings are going. We do a suck assessment on how well the tongue is rolling from the front to the back, moving the milk from the breast to the back, how well the baby is swallowing. And then we do an assessment on the breast, how well the mother is using the technique that we teach of asymmetric latch to get the baby to latch deeply, comfortably, and have good milk transfer in a short period of time. So we keep following you until the wounds are completely healed, and almost always in that time we have excellent breastfeeding as well. So I hope this advice in advance helps you to understand what to expect when you come in, what will happen after the wounds are released, and we will answer any questions that you have at the visit. You can also send us questions ahead of time if you have specific questions after viewing this video, and we'll be happy to respond to you. We look forward to seeing you in our office.